Good morning, everyone, and welcome back. We are going to kick off with our very first, true conference session, not the pre-conference session. And I'm very excited to have Leanne Weisenfeld with us today. She is calling in from the Munzer MPS Research and Treatment Center in Chapel Hill, North Carolina. And as just a personal kind of anecdote, I will say that Leanne has quickly grown close to my heart. She has just done a phenomenal job. She does in terms of all of the neurodevelopmental areas and working with our kids. And she has seen my son, and I was just so blown away with how well she worked with him and how a test that can often be so hard for parents having to talk so much about what your child can and can't do. And I left that appointment not feeling that way. And I really like to highlight Leanne as an awesome example for how these tests that we have to deal with so much really should go. And I'm grateful that she's here today to help give us some tips and tricks and guide us along. So thank you so much, Leanne, and welcome.
Thank you. That was a wonderful introduction. I don't know what I can say after that, except that I'm really happy to be able to come and do this presentation today with all of you. And I'm so glad to be working with Kristen more closely now. And I'm going to apologize because, as you can hear, I'm kind of losing my voice. So if I have some tea or pop another candy in my mouth, you'll have to excuse me. I'm struggling a bit today, but I'm here and I'm going to share my screen now. And yep, there we go. I think you all should be seeing my presentation. Kristen, please feel free to pop on if you're seeing the wrong thing and let me know. That was a great introduction, but I'll just take a quick second to introduce myself as well. As Kristen said, I'm at the new Munzer MPS Research and Treatment Center, which is here in Chapel Hill, North Carolina. It's a wonderful place, and I joined about 18 months ago or so. So I'm somewhat new to the MPS community. However, before joining this group, I've done this kind of work for about 20 plus 22 or so years. I have a lot of background in other sort of rare diseases. I do a lot of Fragile X work, Angelman syndrome work. That's something I'm still doing at this time. Lots of background in autism. So I get asked a lot about my autism expertise as well. So I am learning a lot. So I welcome any kind of feedback or information that you all want to share with me. As like I said, I'm learning as well, but I've really enjoyed it. So what we're going to do today is I'm going to talk to you a little bit about kind of the purposes of the testings that we do, give you an overview of some of the main assessments that we use. There's one that I'll focus on the most. It's the one I tend to do the most with this community. Then we'll talk a little bit about, the impacts of an MPS diagnosis and all the things that come along with that have impacts on our testing. I also really like to make sure to highlight my strengths-based perspective that I sort of try to approach everything from. And I think this is hopefully something that Kristen is sort of touching on when she talked about how I worked with her son maybe a year or so ago. Some of the realities of testing, the good, the bad, the ugly, all of the in between, and what to expect as a parent. And a clinician, but there's a little bit of both in here. I think it would be helpful for the different audiences to see. Also, that's Dr. Munzer, for those of you who might not know, with one of our newborn screening kids that got picked up on newborn screening, and we're now working with him. He's a wonderful little boy. So the first thing we're going to talk about is kind of the whys and the wheres that we are talking about with testing. So why do we do these kind of tests? They can be difficult, they can be arduous, they can be not fun for sometimes the kids or the parents. I try to make them a little bit more fun, but the reason we do these standardized assessments, if we want to monitor growth, development, and definitely with this community, the decline of our patients. Because we often work with clinical trials, they want to see if the drugs that we're trying are working. Sometimes before a diagnosis even, that's when doing these standardized tests has picked up on the decline. So it's important for families to kind of be getting these if they're having any kind of concerns. And then you kind of have a marker to refer back to when you see that yes, there has been a decline, or, oh, look, speech therapy is working, there's been growth. So these assessments also might be used for diagnostic purposes. So this could be things like getting an autism diagnosis, which I'll go into a little bit more later. Checking on the level of impairment or the level of strengths so that there's a place that people can start to kind of know about school placement, what kind of therapies are needed. Even though these tests are not perfect, they do kind of give a place where clinicians all across the country, all across the world, can kind of come to and see the results and know what they mean. So you might see, excuse me, you might see these tests being done with, your child or your adult in a clinic setting as part of like a complete workup. So we do that here at the Munzer Center. We have people come for consultation visits, and they can opt to see me, and I can do some sort of developmental or cognitive testing with their child. You can be a part of a clinical trial. So I know if there's any of our folks on here that are part of the clinical trials that we do, I see you a lot, and we make it through these tests. And but it's very important because often the results of these tests are part of the outcome measures that the clinical trials folks are looking for. They want to see if things are getting better, getting worse, where they're changing, what it looks like. You might be seeking a diagnosis, pre-MPS diagnosis. You might be getting testing and do these things. Oftentimes schools also want some of these tests done so that they can know what is the best placement for your child. So you're going to see these potentially in this community a good bit. So I want to go through, I'm going to talk just real quickly the type of tests you might encounter that I'm going to go over today. So there's developmental testing, IQ, cognitive testing, which is a little different from developmental, and then achievement testing, which is again a little bit different than that. There might be just the straight diagnostics that you get. I would like a diagnosis for autism. I wonder about a diagnosis of ADHD, which I'm not going to go into ADHD as much today. A lot of ADHD diagnosis comes more readily from your pediatrician or some forms that are easier to fill out. There's some forms, if anyone wants to ask me about them, that are kind of the gold standard in the ADHD community. The other kind of test that you might encounter is adaptive behavior. And I'll get into that more later. I think a lot of you have probably done our main adaptive behavior assessment, which is the Vineland. So it might sound familiar. So the first thing, and the one that I'll go the most into detail about, is the Bailey. So there are two different versions of the Bailey that are kind of being used in our various clinical trials. If I'm doing a clinical workup, I'll use the newer one, which is the Bailey 4. I think it's a better instrument. It's got more detail to it. It's got more availability for our kids to get scores. It's not just did or didn't. It's did partially as a 1, did it all the way as a 2, etc. So I like it. It's got more flexibility. This is basically the gold standard of developmental assessments. Researchers use this. Some of my previous work was a lot more in autism research. We've been doing the Bailey for a long time. Before that, it was the Mullen. Now it's the Bailey. This is the big one that people do. So as you can see from the test kit there, a lot of this can look and feel like play to the child that's doing the assessment, or to the kid. So that's kind of great. Sometimes they're not the most interesting of toys. They don't light up, they don't spin, but we try to make them as interesting as possible. And I'll get into that a little bit more later. They give full scores for kids up to 42 months of age. After that age, in this community, we still do the Bailey because of perhaps the functioning level of the child, but we can still get age equivalents, which are really helpful. We can track raw scores, we can track growth scores. So it's still an important assessment to use, even if your child is over the typical age range of this test. It can be done in 30 to 90 minutes. A lot of times it's closer to 90 with some breaks and some playing. The big thing, and I'll again touch on this more when we talk about clinicians, is you must be adequately trained on this. My recommendation is to be working with somebody who has done this test with all kinds of other kids and maybe even kind of learned it with neurotypical kids. So you kind of know what the instrument is, you know how it's supposed to be administered, you know what all your pieces and parts are and what they mean. Because working with kids with rare diseases, it's going to be a little more hectic, a little more frenetic pace, a little bit more throwing things in your bag. So being really set up for success is going to be adequately trained. So what does the Bailey tell us? So there's three big areas: the cognitive area, which is going to look at things like attention, memory, manipulation of things. There's some puzzles. It looks at language, receptive and expressive, and then our motor scales, which are always going to be fine and gross. Fine's the little movements, gross is the bigger things. So the cognitive subdomain is typically the one that has almost the most meat to it and has the most items to give. So with younger kids, you're going to have interest in new things, attending to objects, manipulating toys, object permanence, which is what's happening in this picture. There's a ducky that you can maybe see a little bit in the corner of that picture. Chuck the ducky on the floor. Does the child look towards it? Object permanence, following, some problem solving. We're going to get into some matching puzzles. This one has a lot of items, and it's going to be kind of the big first section that most clinicians will focus on. Then you have the language subdomains. You're going to have receptive, which is what kids understand and hear. So as you can see here, I'm working with, this is one of our girls with San Filippo, and I'm working with her. And since I have this picture up, I'll go ahead and note we're on the floor, right? We're sitting how she's comfortable. She didn't want to sit at a table. She was done sitting in mom's lap. So a couple of other things in this picture that are important is getting down on her level, being with her. And as you can see, and I'm going to touch on this a bit later, I just want you to see it in this picture. She has her chewy in her mouth, right? That's when you're doing pretty much anything except the expressive language part, or you've already heard everything that the child is going to produce for you. Having that in the mouth so that they're not grabbing that book and putting the book in the mouth instead of paying attention is going to be important. So again, receptive language, you're going to identify objects, point to things at books, play interactive games. Do you alert to your name? Do you like to listen to books being read? I love this picture to talk about the expressive language domain, because I think a lot of parents potentially dread the expressive language domain because, my child maybe doesn't talk or doesn't talk much. But this is a picture of one of my favorite guys, Garrett, and he is pointing, and that's expressive language. Garrett's showing us stuff. He's using a gesture, right? He might be requesting that he wants to go on the plane. There's a lot of things you can get from observing these kids, and it isn't all about expressive, actual language that is produced. We have the fine motor domain. You will always see Cheerios come out. I feel like I've been working with Cheerios my whole life. I always have some on hand. Lots of these red blocks, maybe using crayons. It's going to be the smaller movements. And then there's gross motor. A lot of the gross motor things that the kids are going to be doing during the Bailey, a lot of them can be observed during the testing. The kid gets up off the floor by himself without touching something. He crawls really well. Oh, look, Garrett's running and jumping. Oh, watch, he's almost balancing on one foot. So that's a lot of observation there as well. Let's see. So that's kind of a brief overview of the main developmental test that most of you will see. I'm going to get into more detail about the tips and tricks in a little bit. So some of the other things that I said we would talk about are the cognitive or IQ tests. So I have two examples up here on the screen. One is the Kaufman, that's that KABC, and one is the WISC down below. It's a Wechsler test. There's a lot of those out there. These are usually for kids who are a little bit older, have a little bit more abilities or skills to do things that are kind of a tabletop test. There's less flexibility with these. It doesn't feel like toys. It's more structured. It can be a little bit more challenging to administer because, again, it just isn't as interesting to some of our kids, or maybe they can't manipulate those puzzle pieces you see, even if they would maybe be able to understand how to make a puzzle or put a puzzle together in their head. So there can be pros and cons of these kinds of tests, and it's important to keep those in mind when your child is being presented with one of these. Again, we use some of these in our clinical trials, and I've had mixed success with each of these. However, again, lots of breaks, lots of other things that I'll talk about, and they can be done. The other thing, we don't really do these much in the clinical trials. I don't even very often do them in the clinic space, but your kids might be asked to do achievement tests in a school setting. So these look a lot like our cognitive or IQ tests. The difference is they're more actual, not just testing intelligence, but testing achievement. So things you might have actually learned in a school. So they might include actual math, actual writing to see about doing letters, spelling, reading. The other tests we've talked about don't test that as directly, right? This can feel very much like school. Read this passage. I'm going to ask you questions about it. Write this out. Again, you might only come across these really in school, or this is something you could ask for if you want to know where your child is functioning on an age and or grade level. So screening for autism, that is a big thing that I'm noticing in this community that maybe I wasn't as clear when I first started that I would see so much. However, as many of you might know, when you're starting your journey, so during your diagnostic journey, a lot of times these kids, our kids are mistaken for just a pure autism diagnosis. Oh, I think it's autism. And they're going to screen. So they're going to do different questionnaires, interviews, clinician-led testing. As we know in this community, it's not just pure autism. There's another reason, but you might see these tests or be asked to do these in your diagnostic journey. They might want this done for school placement. Should your child be in an autism classroom? How appropriate is that? And the biggest thing that I'm seeing recently is families asking for an autism diagnosis session with me, or me telling them to look for it in their community because they need that diagnosis to receive services. So unfortunately, a lot of times just saying my child has NPS doesn't get you ABA, right? There has to be a documented autism diagnosis. And that's unfortunate, but for now, at least, that's the way it is. So I have done a few, and I'm sure there will be more, where myself and all of my colleagues can say, oh, I can see you would definitely meet a diagnosis for autism. So if we do a clinical workup and I can do some of these tests with them, then it's something that they can take back to their community. So what do these look like? I'm not going to touch much on this one. This is one we definitely did a lot in my other position with autism research, but it is the gold standard of the interviews that you might do with a parent to see their feedback on what the home life is like, what school life is like, about social interaction, communication, and the things that also have to be seen to have an autism diagnosis, which is restricted, repetitive, or stereotype behaviors or interests. Some of you are probably smiling, saying, yes, my kid is really into their trains, or they do some hand flapping or things like that. So that's kind of what we're looking for. The biggest thing that I do in our clinic setting here is the ADOS, and this is the gold standard, and you must be accurately trained and certified to administer this. So make sure you're not getting someone who says, yeah, I'll give an ADOS a try, because there's a lot of training and making sure that you're able to do it correctly that goes into this. So the ADOS, as you can see here, that's a big old kit. There's a lot of toys in it, but that's the good thing, is that it feels very play-based. There's a part where you just put out a circle of toys, and I just get to watch and see how they interact with those toys. Some of them light up, some of them spin. What am I looking for? How much while they're playing are they showing things to me, showing things to mom and dad, wanting to share? Are they doing pretend play? So there's a big circle of toys. There's other things where we maybe blow bubbles and see how the kid reacts to that. Do they request? This is a great instrument. I've done it many, many times, and this really is the best way to accurately see about an autism diagnosis. When kids are a little bit more older, have a little bit more verbal or functional abilities, there's going to be more like storytelling. Let's look at a book. Let's talk about creativity. Or even as they, get older, you can talk to them and see how in tune with their emotions they are. What do they think about friendships? And all of that is information that you put together and you make a diagnosis with the ADOS. It goes really well with the ADI I was talking about, because then the parent can tell what they see at home and in school as well. The last big one that I'm going to talk about that I would imagine a lot of you have done potentially many, many times, and I know I have, is the Vineland. So this is, when I mentioned earlier, we would talk about adaptive behaviors. This is the adaptive behavior scale. So this is the best way to do it. There is technically a questionnaire parents can fill out, but the better way to do it is the interview form with a parent or a caregiver of anybody in a study, clinic participants. So adaptive behaviors are what the activities that somebody can do in their personal life, in their community, how they manage their environment, right? So this is something that we can't necessarily, it's all the things I can't see necessarily when your child comes to see me. So what are we measuring? We're going to talk about communication, which again, we test in some of those other tests. But as you all know, the kids sometimes they clam up or they don't point to something in a book, even though they can do it. Daily living skills, which are really important. These are, how self-sufficient are they? Are they potty trained? Do they help with chores? I'm going to hear about socialization. How do they play with other kids? What does play with mom and dad look like? Motor skills. This is, again, instead of me saying, can you balance on one foot? It's like, hey, do they like to ride a bike? Can they throw a ball? Tell me if they're in any sports. And then sometimes we talk about maladaptive behavior. So that a lot of the clinical trials ask for these questions to be answered about, kind of things that kids might do that we don't really hope for them. And then by getting that information and seeing if it changes, they can kind of make some decisions about how effective potentially the drug that we're testing is. So why is it so important? So these can, I'm sure, feel pretty arduous to parents when they've done it a lot. I know some of my families are like, oh, here it is again. I've done this a million times. But because this isn't directly administered with the participant, so your kid isn't being put under any undue stress, it's not influenced by these outside factors. The kid was tired that day. They don't feel well. They didn't like the testing room. But one of the biggest things I think is important is that families often change their priorities as they get a diagnosis or as abilities change. So I like to talk about this family that I saw who their child had Fragile X syndrome, and I went to their home. I used to travel across the country and do these assessments, do all the neurocognitive stuff, do some developmental testing. Maybe he's not putting pennies in a slot. Oh no, right? That's one of our tests. But what does putting pennies in a slot really do for this child that I'm talking about in real life? But when I did the Vineland, mom was able to tell me that, they're not going to focus on necessarily block stacking and putting coins in a slot. What was important to them is that he had functional skills. So she told me, and then I got to see how her son could go into the kitchen, get a bagel, get his knife, put it in the peanut butter, and spread peanut butter. So when he got home from his day of school, he was learning to be independent in getting a snack, which doesn't just help mom and dad, it helps him be able to potentially live in a more independent way in his future. So I really love to hear these interviews because I love to hear what parents are doing in that way. I think it's very important. So they're not going to spend their days in testing. They're going to spend their days in their environment. So obviously I don't need to go over the challenging behaviors that we see in MPS because I think everybody here pretty much knows about them. But these things that you're seeing up here can kind of play a part in what happens when you bring your child in for testing, right? They might have some aggression, they might be chewing or mouthing, they might have some anxiety. So what kind of impacts does this have on testing? How can we as clinicians gather the most valid, accurate data when we're faced with these challenges? The first thing I'll talk about is strength-based perspective. I'm going to talk about the clinician being prepared, giving guidance, myself and other clinicians, to the parents or caregivers and what you all as caregivers can do in these testing environments. And the biggest thing, because it goes all in every person, the clinician, the parents, the everything, is to be flexible. Even with standardized instruments, flexibility is key. So first thing we're going to touch on is the strength-based perspective. I love to use this in my presentations because this guy here, this is Aiden, he's 16, and this just to me really showed strength. Aiden has an autism diagnosis. He does have some physical symptoms of MPS that he suffers with, and also flourishes with, I should say. But he has an attenuated form of MPS, but he loves to be dramatic. He loves to perform for others, and he is using his strengths to go share that with his schoolmates and people in the community. His mom said that his treatment is literally giving him life, and he's living life to the fullest. And this is a good example of him doing that. I got some feedback from families before I did my first presentation about this. And I said, tell me good things about your kid. Tell me strengths. I feel like, everyone focuses on the hyperactivity, the potential aggressive behaviors, the emotionality, the mouthing, but I got lots of good feedback, things that I would most certainly agree with in my time in this community. But it's important as a clinician and as a parent to remember all the strengths and to utilize them while we're testing with kids. Loves to sing and perform? Great. Let's do some pretend play with that. Imaginative, determined. I definitely see that with these kids. Tenacity. I mean, look at this guy here. Sweet, cute, all the things. So as a clinician, for any clinicians on here, and this is important for parents to hear too, because this is what you should hope for and expect from a clinician who is working with your child. I would want to and need to explain the assessment before administration. So one of the biggest things that if I ever forget, I always make sure to go back and tell parents is, by the way, for most of the developmental tests, I have to administer items that they're not able to do before I can stop administering. We want to make sure we take them as far as they can. So you're going to see your child, air quote, fail on some items. That's kind of the nature of the test. It's the nature of, who knows, they might surprise us. So we need to keep presenting items until they can't do that certain thing anymore. Your clinician should be encouraging feedback and input from you as a parent or a caregiver. There's a fine line with that, which I'll go into a little bit more. I think it's important for me to remember that parents are the experts on their child. I might be an expert of knowing what the Bailey is, but you know your child. So just keeping that in mind always kind of keeps things in perspective. It's important for a clinician to maintain integrity of the test, even when encouraging feedback, incorporating all the strengths. There's certain items that you need to do a certain way. However, after you're done knowing that the child can or can't do it, you can let the kid play with that item. You can let the kid succeed with that item. Putting the coins in the slot, help him a little bit, make him feel happy that he did it, but maintain the integrity of the test and know that they didn't do it independently. A clinician might need to set boundaries, both with the caregiver and the participant, the child that they're working with. As much as we as clinicians want feedback and input, there are boundaries there. So it's a very fine line, and I encourage you to ask your clinician who's working with you, like, is it okay if I say it to him this way? Or what about trying it that way, before stepping in too much? Too much input for these kids can be overwhelming, and it can kind of interfere with the integrity of the test if you do too much. And of course, incorporating the strengths, as I talked about. So some other ways that I try to prepare for success is scheduling the assessment at a time and in a way that is best for the child. So you can see here, one of my little guys, sometimes he's really sleepy. We don't want to do it we want to do it when he's ready to play, he's ready to go. So I always ask parent, what works best for you? Typically that's morning with kids, maybe not all kids. As I talked about, knowing your assessment instrument, be open to the feedback and the input that the parents are giving you. Comfortable testing space. So it's really interesting that at the New Munzer MPS Center, we have our very own room with a window for observation, neurocog testing room. However, we realized over time that it's in the same building, in the kind of on the same hallway as where a lot of our kids come to get infusions every week. So some kids were having a little bit of a reaction to that, and you'd have to say, no pokes today, don't worry, no pokes. So we actually, because we've already grown as a center so much, we actually have a new spot right kind of across the street and up a level. And we're going to move our neurocog testing room over there. It's a whole different space for the kids. It can feel different. They're not seeing the scale when they come in to get weighed. They're not seeing a blood pressure machine. And sometimes that can be really important to kids. Make sure the place is comfortable. Close the mirror if you need to. The biggest thing is expect the unexpected. You know, you might have a kid throw up in the middle. You might have a kid need to do everything standing, need to do everything on the floor. And being flexible with that is really important so that you get the best information from the child. And taking breaks and having snacks. And that's something that is okay to do. You know, we can incorporate snack time, we can have break time. Sometimes break time can mean running up and down the halls and you're actually doing a gross motor assessment and they just don't happen to know it, throwing a ball back and forth. So that's really important. So the challenges and their strengths are equally important. So you have to meet the child where they are, right? You have to, how are they feeling today? You know, maybe they're not doing well. Sometimes you have to, like I like to say, match their energy, but we're ready to change. Sometimes kids, they like a lot of input. They want, yay, good job, and claps. But other times that's overwhelming and they just want to, nice, you did it. That's great. Check in with the parents. Do they like clapping? Oh, I didn't know clapping is not one of their things they like. Oh, they like a quick shoulder squeeze when they do something right. It's really important to get that information and to kind of incorporate it into your assessment. Addressing sensory concerns, if there's noises or lights or the need for something in the mouth, a chewy item like I mentioned before, make sure you address that. So I like to put this one in here because, you know, this is again one of my San Filippo girls that is very into pretend play. She's very dramatic. She wants to be into pretend play. So you get on her level. You know, when I was working with her one of the first times, we used a pretend phone to call the princesses after every time she successfully at least attempted an item for me. Okay, well, if you do this one, we can call the princesses. And that was it. She was just so excited. You got to kind of join in their world, see where they are, positive reinforcement. And if the parent wants to do a reward system, then you roll with that, whatever works. Okay, so I'm hoping my let's see, sound shares. But this is an example that is like a training piece for the Bailey gross motor. And this is what the training example looks like for this item. I want you to see this. Hope you can hear it.
Chopping M&Ms. All right, how about this? Can you bounce on your right foot? Okay, bounce on your left foot.
Okay, can you balance on your left foot? Can you balance on your right foot? Say that and the kid just does it, right? Sure. here's one of my friends. And you can see there's lots of other things going on in the room, and we had a lot of fun playing. And then this is what it sounded like.
Okay, I'm taping.
You gotta hop on
Watch,
one
you gotta
foot.
hop. Let me see those feet.
Can you do it on one foot? Hey, look at mommy. Can you be a happy cat? Can you
Let
be
me
a happy
see.
cat? Here, let's do it. Ready?
Joe, ready?
Look at mommy.
So let's do it like a flamingo. Let's run around the room. This is just a real life example of what testing can look like and feel like, and that's okay. This is the way it goes. And whatever it takes to get it out of that child, saying flamingo, running up and down the halls, that's what you're going to do. But it's just interesting that I think parents often worry that, my kid isn't doing it like the first example I showed you. And that's okay. This is what we see a lot, and that's perfectly fine. So as a caregiver, I talked about how to navigate sessions as a clinician for me, but what about as a caregiver? So I talked about be thoughtful about timing. So don't be afraid to say, I've gotten text, he's actually sleeping in this morning. Can we come 30 minutes later? Not everybody is always flexible, but you can try, right? So we want them well fed. We want them well slept, whatever makes your child function the best. On that note, bring their favorite snack, bring a drink, the sensory items, bring chewies. I think I actually looked, and we have a big bin of them now, of brand new ones that we can share with our kids when they're here if they need it, but that's okay and it's necessary. Ask questions during testing. That's okay. Some you might want to save till the end if things are a little crazy, but don't be afraid to ask questions about what is this testing for, or what is this going to look like. On that note, though, be mindful of interfering or spoiling. My example is if I'm doing a receptive language and I say, show me the cat or kitty, maybe I'll even say, and then the parent says, yeah, where's the meow meow, right? You're giving a different kind of input versus just the word, and it's word identification. If your kid can point and they know it means, meow, a cat meows, that's great. But maybe ask before you say, can I describe it in this way to them? Otherwise, the item is spoiled. And if the kid then points, I can't count it. So ask your clinician if they're open to some feedback. Hey, I think, maybe toning down the excitement, or hey, she really likes positive reinforcement. And just always remember that you are the expert on your child. These tests are important, but it's also important to remember that you have seen what your child can do, and don't forget that. So then the interviews that we do, the Vineland, I wanted to touch a tiny bit on how to navigate those. As a clinician, I like to acknowledge that these conversations can be difficult. I might be asking you what your child is able to do. I may be asking about autism symptoms that are difficult. And to have some active listening, some empathy, allow people to tell their stories. So on that note, allow time and be flexible. So I always like to have extra time in case a family really just kind of needs to unload about how difficult potty training has been. Okay. As a caregiver, know that this might be emotional. This might be difficult to talk about, and that's okay. Just be as detailed as you're comfortable being. Ask clarifying questions, and you are the expert on your child. So to kind of wrap up, I just want to note that all the experiences that myself as a clinician have had with all of these families and all of our participants in our different clinics and our trials, it really influences how I think about working with the next child, and little tips and tricks. I might be the expert in like what a Bailey is and how it works, but I still learn something every day from these kids, these families. It's been an absolute joy to join this community and to work with all of you. So I would be happy to take any questions. There's myself and one of our genetic counselor, Kristen, and with one of our little guys who's a favorite. So I get baby
He's
snuggles,
wearing a
which is
Project
also
Life shirt.
I know, right? How perfect.
Thank you so much, Leanne. That was
You're
really
welcome.
wonderful. And we have a couple of minutes for questions. If
Okay.
anyone has any, you can put them in the Q&A or in the chat if that's easier for you. And if you don't have questions now, but something comes to you later, the Munzer MPS Center has a booth in our expo, which you can send messages through there, and I'm certain that they will get back to you. So we do have one question, Leanne. It says, what should we look for when trying to find someone to do neurocognitive testing?
That's a great question, and it isn't always easy to find. I will say that. When I first started working in the field, I wasn't as good as I am now, even though I can't say I'm great or perfect, but I had a lot to learn. I think if you feel like your child is going to be a little bit more difficult to test, I would ask about, how many years this person has been doing this. What are their qualifications of, maybe they haven't worked with MPS. I hadn't worked with MPS at all doing this for 20 years, but I had other kind of challenging behaviors I'd worked through. The Angelman community taught me a ton about working with kids with MPS, the Fragile X community, autism community. And if you get testing with somebody, and Kristen, I hope you don't mind if I say it, but Kristen had worked with people who just said, well, he's not testable. If you face that, I would find someone else. You can find somebody who can do something with your child. There are different tests out there. There are ways to even just make it a caregiver interview then and say, well, tell me about what your child could do. I want to hear it. I want to know. I want to make notes about this. So you have to look around, unfortunately.
And also just to plug for you, Leanne, if you're having a hard time finding someone in your local area that is giving you results that you feel comfortable with and that you felt like the test went well, and if that's not happening, you can reach out to the Munzer MPS Center. They do have a consultation program, which would include that testing with
Yeah.
Leanne, which you can take those results and bring them back to your own home providers, also to your teachers and all the other people that might need those kinds of results. So,
Yeah,
and one other
we write
question,
up reports and send it out, and then that's yours to do with what you want. You can share it,
right,
you cannot share it. If it doesn't show what you think will help you showing it to the school, you don't have to share it. So,
right, that's right. And one other question was, what are your thoughts on switching clinicians performing the testing in the middle of a clinical trial? Also, my boys are attenuated and we usually don't go in with the boys for testing. Is this normal?
okay, I'll focus on we don't go in with the boys for testing. I always ask the parent which they think would be better. Definitely with an attenuated boy, maybe in his teens, he's like, see you, mom, I don't want you to be here. That's perfectly fine. If you think it would go better, okay, 6 and 9. Again, if you think it would be better if you're in the room, ask the clinician about that. There's not, as long as you know to not interfere, I don't see a problem with that. And at 6 and 9, I'm very, very open and usually have parents in the room, but that is not always the case. And then about switching clinicians in the middle of a clinical trial. Some of our trials had to switch to me because I came on board and our other clinicians are not the main clinicians anymore. It's not ideal, but it's done for a lot of different reasons. A clinician is no longer available. You hire somebody new, and that's okay. I mean, I got information from the previous clinicians about each kid before I worked with them, and that will help kind of the transition.
And I think it's important to, if there are concerns when it comes to the actual clinical trial, make sure that you're talking to your trial site coordinator to
Yes.
have those discussions. And if there's ever anything abnormal and you feel like you're concerned about having those conversations, you can always reach out to us and we can help with that
Yep.
process too. So, and unfortunately, we are out of time. But Leanne, if you are willing and can kind of see some of these questions in the chat and answer them, I think that would be wonderful. Or again, you all can go on to the expo, look for the Munzer MPS booth, and there should be a little question and answer box there. There's also their email addresses, and you can reach out that way. And I would say move your questions over to the lobby chat, because this room will close, and that way Leanne, if she's available, she can answer those kind of via text that way. So thank you so much, Leanne. That
You're
was so
welcome.
wonderful. We're so grateful to have you. We're
Thank you.
excited to have you join us again for our in-person conference in a couple of months. So you'll get to talk to her a lot more there too. And we will all see you in the next session. So thank you all so much.
Bye. Thanks, everybody.
Bye.